All right, so we're going to move on to our patient-centered care section. So for our first speaker, we have Dr. Stephanie Snow, who's a professor at the QE2 in Halifax, Nova Scotia. She's going to talk to us about Lung Cancer Canada and the unmet needs in early-stage lung cancer.
Hi, thanks for inviting me to be here this year. Last year I was teasing Normand that I had flown under the wire. I got to enjoy everything. I didn't actually have to give a talk, so he promised I'd have to talk this year. So I'm thrilled to talk about some of the, are my slides coming? Good. About what we're going to talk about are the unmet needs currently from a patient perspective and a care perspective in early stage lung cancer through the Lung Cancer Canada lens. And it's largely Canadian focused as a result, but certainly these themes probably resonate to our international audience as well. And while we're waiting, does everyone see my beautiful bling white ribbon for lung cancer? I can remember one time Roz Durgans came to spoke with us and she had one, so I immediately had to get one. And after that, Parni Chima wanted one, so I got her one too. I think I owe you one, don't I, Barb? I do, so. Yeah. They're very pretty for those who like pretty things. Okay, it's up, wonderful. I just can't see it behind me. So these are my disclosures. I'll keep looking over my head. So in terms of what we're going to talk about, we do need to still make things better for patients with early stage lung cancer. The best thing to do is prevent it from ever happening. So we need better prevention, better detection, better access to therapy, and then finally better survivorship. So starting off with prevention. We all know that tobacco cessation is very important, and I really wanted to highlight some of the data that came out of the Italian screening program, which had built-in tobacco cessation support, and it showed that those patients who actually had that intervention, there was a 39% reduction in all-cause mortality. So you may not pick up a lung cancer and save somebody with the screening program, but if you can help them and support them in tobacco cessation, you may save them from having a stroke or a heart attack, or worsening COPD, those types of things. And I really find this is not something that's being taught in our medical schools and the curriculums well. And so when I have a junior learner, especially a medical student, and I know they're going to be an emerge doc or an ENT surgeon, they don't want to know the subtleties between picking, what, ALK inhibitor are you going to use, that type of thing. I make sure that they hear me do my tobacco support talk. And so much of our approaches are kind of blaming, and patients get enough of that. They self-blame, and their wife is nagging them, so it has to be a support. And I say it is not your fault that you are addicted to nicotine. People aren't running around addicted to nicotine patches and nicotine gum. It is the tobacco companies' faults for creating cigarettes, and now they've bought all the vape companies. It's an instant drug delivery system. So the first thing you recognize, it's not their fault. Then you recognize it's the hardest thing you're ever going to do, and if you can do it, we're going to be here to support you. But it's hard, and nothing's going to help unless you're ready. And I kind of leave it at that. And those who are ready will then ask for help, and you can talk about the different things that give them a better chance to be successful. But I think that's so important. I think we can make such a huge impact for our patients if we teach that and learn how to do that ourselves well. In Canada, the second most common cause of lung cancer is radon. And this is something, again, that many people aren't aware of. And this is something Lung Cancer Canada, we try to include in our public awareness and those types of things. Now, I come from the province of Nova Scotia, so for our international attendees to situate this, the blue towards the left, that's the Atlantic Ocean. And so I'm kind of like right on top of Maine. If you took a ferry from the eastmost point, the westmost point there, you could go down to Boston pretty quickly. And in this map, that shows areas of high radon concentration. Those of you who know Nova Scotia, you know that area of the very high density that kind of pokes out at the bottom, that's where Halifax is, and that's where almost all the patients or all the people in Nova Scotia live. And the definition of high risk by this map is that means that 40 out of 100 buildings that are tested for radon have above acceptable levels. So it's really common in those areas. Medium risk is still 14 out of 100, and the rest are low risk. So we have a lot of this, and a lot of my patients who are never tobacco users go on to get their houses checked after they've been diagnosed, and it's too late. Also in Canada, but also elsewhere, we do know that a lot of our patients who develop lung cancer are often living in rural areas. Rural areas often goes along with certain occupations based on natural resources. A lot of those carry with them risk. And these are things that can be modified. And the other thing is we've done a great job in the mesothelioma world of making sure that every patient does have that workers' compensation pursuit. But I think that we can do a lot to also support our patients who don't necessarily have mesothelioma but may have had occupational exposures. I have a lot of patients who served with the military, for instance. They could have been exposed to a lot of things and different diesel fumes and those kind of things. So it's something very important to remember about this, and then we can also support each other in how do we write that standard letter. Globally, I mean, this is also a thing in Canada, but globally, lung cancer and pollution is a huge thing. So making people aware and supporting different research, and we're going to come to that in a little bit, is very important also for prevention. So now moving on to detection. Dr. Juergens did a great job of taking us through where we are in screening in lung cancer in Canada. And so there have been some barriers and challenges. First of all, we had to do it for every single one province. And different provinces have been able to do it more quickly and more readily. But one thing we've been able to do at Lung Cancer Canada is kind of bring those silos together. So for instance, Manitoba was developing a program through associations through our medical advisory committee. We were able to share our best practices and what we had done. I've written letters as the president to support every province's business case that was going forward that wanted a supporting letter. And so we were able to bring some of those things together. Geography is a huge issue regardless of what province you're living in. You're going to have patients in rural areas who will not be able to access screening as readily as somebody who lives in a large urban center. And as we just talked about, those are probably the patients who would stand the most to benefit. There's also uncertain future for many of our pilots. We saw recently in Quebec, where they have a real crunch for getting access to CAT scans, the screening program was actually under threat. So again, Lung Cancer Canada, we collaborated with a number of other lung advocacy groups to really put a lot of pressure to say, well, you guys have done a great job starting this up, we have to continue this good work. There are also issues for inadequate resources downstream. So in other provinces, for instance in Ontario, they're really struggling to get access to the PET scan, which is an important part of staging. We've actually found the lung cancer. So our immediate past president, Paul Wheatley-Price, who wasn't able to join us today because he's doing some residency work, he's done a great job really advocating at a government level to try to get more access to PET scan, for example. And finally, Canada has a huge shortage of primary care providers. So it's so important that these screening programs have the ability for patients to self-refer, but patients may not even be aware. And as we're going to talk a little bit later, sometimes our lung cancer patients are more prone to have a lower level of education and lower health literacy. So these are not the people who are home, reading the Toronto newspaper and, doing the Wordle and those types of things and seeing an article on lung cancer screening. They may not even be aware of it, let alone how to self-refer and if they are a candidate. So one of the great things that we've had at Lung Cancer Canada recently is this Mike Bossy Memorial Fund. So again, our international attendees may not know who Mike Bossy is, but he's a hockey hero. One of the top 100 NHL players ever, Hockey Hall of Fame, played for years for the New York Islanders. But he is a Canadian, he's actually from Montreal. And so he passed away from lung cancer, and he would have met the criteria for lung cancer screening had it been available in Quebec at that time. And so his family, to commemorate him, have started the Mike Bossy Memorial Fund with Lung Cancer Canada, and really the focus here is to try to support and promote screening in Quebec. Now, it's great if we can have our screening set up, but then we have to get patients to go. This just turned up in my ASCO Post email like 2 or 3 days ago, showing the very low rates in the US where they do have fairly good access in most states. It's only 18% of eligible individuals are up to date on their lung cancer screening. So we need to make sure that we're actually getting our patients out as we build these programs. And I like to say that this was my height of my fame as president of Lung Cancer Canada. This is me being interviewed during the second intermission of a New York Islanders versus a Habs, or the Montreal Canadian hockey game. And this was an entire game that was dedicated in memory of Mike Bossy. And the 50-50 draw went towards setting up the Mike Bossy Fund. And I got to tell all of America, plus Quebec, because we got it on Radio Canada, about how important screening was. And it wasn't my words. I said, Mike would want you to get screened. And these are people for whom Mike Bossy was a hockey hero. So in that moment, I touched more potential patients, or hopefully kept them from being patients, than I ever will. So I wanted to mention that as well. Another great thing that we've done at Lung Cancer Canada is to promote research. And so with our partners at the Lung Ambition Alliance and AstraZeneca, we're in our second year of the Lung Ambition Awards. We have $100,000 of research money that we give out every year, and last year and again this year, it's going to be 2 grants of $50,000. And these are the type of research projects we really want to focus on supporting: enhancing early detection, improving healthcare systems, and improving disparities. And I'm very proud that Anna McGuire, who introduced it as the chair here today, was our winner, for one of our 2 winners in 2023. And Anna's research is really great. And so she's doing research on pollution, the exposure of that, developing lung cancer in non-tobacco users, especially with EGFR mutations, and this may change the way that we do screening in the future. Now, the 2024 winners are going to be announced later next week once we shoot the videos and put out the press release. And I was told I'm not allowed to burst the bubble. Now, the winners already know. One of the other winners is in this room, and she knows who she is. But I wanted to highlight, by redacting the information I'm not supposed to share, one of the other projects. So Dr. Blank from the Institution of Blank is doing this great work looking at blood-based testing to help stratify and find more patients, including potentially those who have been never tobacco users, to really focus in screening results. So here we have 2 years of this program and 2 really great screening research projects that we've been able to support. Now, moving on to therapy. Roz took us through some of this earlier today, and you probably can't read a lot of this. I apologize if it's too small, but this is from our Lung Cancer Canada Faces of Lung Cancer report. And what this table shows are different indications for therapies for lung cancer. The blue ones are early stage. And the reference number is the date that that drug got FDA approval. And what we show is per province, how many days compared to the FDA approval our patients in Canada went before there was actually access. And we can also see as you go across provinces, some provinces still don't have access. And even for the superstar one that we're proud of that Roz talked about, the neoadjuvant nivolumab, where we got the last step of HTA through in 2 weeks, on average it was still over 500 days compared to the first day of FDA. So that was periods of time where Canadian patients were not able to access therapy. And also, what does funded mean? Every province has their own medical system, and out west, where they have cancer agencies, when Barb sees a patient in clinic, it doesn't matter if it's an IV therapy or a pill. She does the prescription, it is covered. But once you hit Ontario and move east, it's very different. And for oral therapies, it's exception status. And exception status in many provinces mean that you qualify for the seniors pharmacare equivalent, so 65 or older. Or there are some catastrophe plans, especially based on income, but those take a while. So as we're seeing this great data come out with more indications for our oral agents, we've just seen that at ASCO this year with a new indication for consolidation with osimertinib. We've seen the great ELINA data for the first data for adjuvant ALK therapy. We're going to see more and more of our patients be challenged, and almost by definition, these are our younger patients. We're more likely to see those with driver mutations be less than 65. So this is really important as well to advocate for equity in access. And this makes a difference. Now, this is some data that actually was taken from the advanced lung state, but what they looked at was the total overall survival life years lost from the point of efficacy being proven to getting funding in Canada. And we're talking huge amounts here, 39,000 for lung cancer. And now when we're talking about things that are curative intent as opposed to advanced disease, we can only imagine how astronomical that impact will be when our patients don't have access. So finally, moving into survivorship. So there are many survivorship issues, and they're certainly not unique to lung cancer. We see them across all tumor types. But lung cancer patients do have some unique or perhaps more augmented challenges that they have to face. and they fit into different domains. So from a physical perspective, if you have permanent neuropathy from platinum chemotherapy, if you lost some of your hearing, or if you maybe only got 3 cycles of IO, but that was enough to give you type 1 diabetes, you're carrying that physical impact for the rest of your life. From a social perspective, we're going to show some slides in a second even more to drive this point home, but lung cancer disproportionately impacts those of a lower socioeconomic perspective. And so if a patient has chronic fatigue and they're less likely to be able to go to work, that's going to have an even bigger impact on them. Lung cancer also still carries a stigma. So some patients are proud of their survivorship and they can wear it bright and tall, but some people are still embarrassed to ever say that they had lung cancer and to get that support, and they self-internalize and they self-blame. And that is something that can lead to very poor mental health issues and those types of things. There's a lot of emotional stress. Most patients are still aware there's a significant chance of cancer recurrence. And finally, there's specific medical follow-up. If our patients have lower health literacy and they live in rural areas, it may be much more difficult for them to attend those appointments, to get time off work if they're working minimum wage and don't have sick time off, to get their follow-up CAT scans. All of those things are important. This is some very compelling data that shows the impact of income on survival. And so each one of the different colored bars is a different quintile of income. So those who are in the red bars are in the top fifth of incomes, and those who are the kind of purplish color at the very end, those are the lowest income. And they're grouped by stage, and we can see regardless of stage, there is a huge impact on the 3-year survival rate on the basis of what your income is. So really driving home how much more a financial toxicity of a cancer survivor may have an impact that really makes a difference. There's a lot of things we do at Lung Cancer Canada to highlight this as we're getting towards the end, some of our great projects. The Kayla's Angel Fund is there to help people with those financial toxicities. So a great example is I had a patient, she wanted to participate in an adjuvant lung cancer trial. She lived about 3 hours away. And Kayla's Fund was able to provide her with gift cards for Tim Hortons so she could get some food on her way down and pay the gas bill so she could actually participate in the trial just as easily as somebody who lived across the street. We have the Airways of Hope, which is something that we're able to fund a social worker in conjunction with our support from our industry partners. And she's created a network of social workers throughout other provinces so patients can get that help. It's sometimes easy to get a social worker if you're still in the system, but if you're a survivor and you're running into these issues, you may not have anyone to go to. We have the online support groups, not just for our patients, but for their loved ones, their caregivers. And we do provide formal training in the peer-to-peer program so that lung cancer survivors and patients get formal training so they can be a support and a counselor for others who are going through the same things. And finally, the Hope Army, that's our social media team, which is made up of doctors and nurses and loved ones and patients. And every once in a while we have a message, we have to get it out there to really try to put it through social media. And finally, we try our best to fight the stigma each and every day. And so this is a campaign we did in conjunction with the Lung Health Foundation about stop asking the wrong question. The wrong question, of course, being, did you smoke? The right question is, how are you doing? Or what can I do to help? And really trying to change the lens on lung cancer because nobody deserves lung cancer and anybody can get lung cancer as long as they have lungs. Thank you very much. Do we have time for questions? Or?
I believe we'll leave all the questions to the end for the panel.
Okay.